Thank you, Jim. And I also wanted to thank Professor Coxhead, because while we're talking about two very different topics, the first and the 8th Millennium Development Goal, there's actually quite a bit of relation between the two. One of my colleagues asked the question, are people sick because they're poor, or are they poor because they're sick? And in fact, we know that poverty is the primary determinant of health. And so there are big connections between poverty and global health. And I'm glad we had such a fascinating presentation. I wish we had more time, and we will, to talk about it somewhat. So I'm shifting over to the 8th Millennium Development Goal, and that is develop global partnerships for development. And so you can see over the course of this series, you've talked about most of these, but I'm going to focus in on partnerships in particular, how they've evolved through our Center for Global Health, and I'll give you a particular example of a current partnership underway in Ethiopia. But I'll also touch on the importance of partnership for development, both at the United Nations level as well as the US government, and what has driven this urge for partnership. Briefly, the Center for Global Health was established in 2005 with collaborations particularly in the health sciences schools, but also across the campus. And as we developed, it was really in the spirit of trying to bring together people from across the UW-Madison at least, and surrounding communities, to coordinate our efforts to promote global health, because we realized there was a great deal of interest and many people involved, but little communication or coordination of efforts. And so as we met, and many people here in the room were involved in the development of the center, we focused on the principles of our center and why we existed and what we were really about. And I'm bringing this up because the guiding principles, I think, not only apply internally to our university, our Center for Global Health, but also these principles and values have driven the development of partnerships that I think I would encourage you to think about in terms of partnerships for global health. But first and foremost, an emphasis on equity, meaning that our projects and programs would focus on where the need was greatest, where the disparities were strongest. So we might end up targeting our efforts at improving health for those least fortunate. Focus on reciprocity, mutual benefits, sustainable, long-lasting impact, and also interdisciplinary, because we know health is really impacted by so many broad determinants. Everyone could have a role. And so over the years, we've developed a number of programs in education, research, service, and I'll focus now on the partnerships that we've developed and the principles for partnerships. We realize that many universities and countries are partnering together for health, but we felt that at UW we should distinguish ourselves in terms of what were the elements of partnership that could reflect our own values, the values of our university, faculty, and students, and that we could really ensure would enhance our opportunity to make a long-lasting difference. And I'll tell you that one of the reasons we developed these more explicit principles is because early in the development of our center, literally almost every day or week, another person would come along with a fantastic idea for a partnership with the UW-Madison. And so we had to come up with some really distinguishing characteristics that we would use as a litmus test to determine whether or not to proceed with a partnership and invest our resources in that relationship. And initially, we realized that a true partnership must be based on relationships. It has to be based on relationships that provide mutual benefit, but also that promote learning. We're a university, and so our primary purpose is education, as well as research and the discovery of new information. And so we wanted to be sure that our partnerships really reflected those primary goals. that there would be trust, transparency, sustainable collaborations, and that we might be able to take the lessons learned from our international efforts and actually bring them back to Wisconsin so that our global efforts were of benefit to Wisconsin as well. And this is just a few of the partnerships that we have underway. Dr. Conway has been very involved in working in Kenya. We have educational programs in Ecuador, Thailand, through the School of Pharmacy. Dean Roberts is here and has been very involved in pharmacy education. We have courses there. In Uganda, we've been involved in training family physicians. Professor Bauman has been improving the care of people with diabetes. We've had programs, James and Tomby, to improve nutrition and food production and nutrition education. So we have already a very robust and full set of partnerships. And I'm going to focus on the one that's currently underway in Ethiopia and reflect on how this came about, both from the international and the U.S. government perspective. And I wanted to bring you back to a lovely quote by Julian Tudor Hart, a generalist physician in England, who stated the inverse care law, and that is the availability of good health care, medical care, tends to vary inversely with the need in the population. And in fact, we see this around the world. We know in terms of numbers that at least 1 billion of the 7 billion people in the world lack access to health care. We know that 50 million in the United States are virtually having major challenges in terms of access to health care because of financial barriers and so forth. And so we have a major problem in global health in terms of access to health care services, although we know health is determined by many other determinants and not just medical care. In fact, access to medical care may be one of the least important when you look at poverty and other factors. The World Health Organization has long had a lens on trying to improve the opportunity for health for all and to reduce health disparities. And Lee Jong-wook, who was Director General of the WHO, articulated very clearly that we have a world torn by gross inequalities in health. And these inequalities are in many cases deepening and widening, even in countries that we're seeing progress, such as China that you just heard about. We also know that many determinants of health are lying outside of the health sector. However, scaling up of health systems is really a fundamental tool for improving health outcomes. And that without access to health care, and particularly without access to primary basic health care at the community health level, it would be very difficult to actually impact health, especially health disparities in low resource settings. Now, at the U.S. government level, the Obama administration launched the Global Health Initiative in 2010. And the initiative was very clear in identifying health at the heart of human progress, and health as actually a very important mechanism of foreign policy and engagement of the U.S. government in the world. And so the Global Health Initiative at the government level has really focused on global health investments as a feature of our own security, our diplomacy, and our development work. The idea is that if we invest in health, it will not only improve the health for people around the world who need it most, but will also ultimately ensure our own stability and security. Now, I wanted to show you this slide because it's so striking what's happened in just the last 9-10 years, and that is the increase in access to antiretroviral therapy in low and middle income countries around the world. And the increase, particularly the increase that you see in sub-Saharan Africa, is largely due to the largest global health investment in the history of the world, and that is the U.S. government's investment in the President's Emergency Plan for AIDS Relief, the PEPFAR funding, that rapidly scaled up access to antiretrovirals, particularly in sub-Saharan Africa, in Asia, and in East Asia. And this has really been a resounding success. It's been one of the most rapid and striking scale-ups in the world, now with more than 5 million people on antiretrovirals who were not just 10 years ago. And most certainly, those 5 million people would have died of HIV/AIDS had they not been treated. So this is a real success story in terms of investment and payoff in global health. Unfortunately, the sad side of this is that the number of new HIV infections is continuing to exceed the number of people going on antiretroviral therapy. So a lot of work still needs to be done in terms of prevention. Now, this slide shows one of the main challenges that we've noticed in terms of scaling up antiretrovirals and the investment in AIDS therapy is the fact that we have not been able to meet the minimum human resources for health goals in many parts of the world. And you can see here on the left the global, excuse me, let me just, no. Go back here. You can see the global average of human resources, health workers, is 4 for 1,000 people. And that's actually the minimum threshold that's recommended by the World Health Organization in order to meet even very basic primary medical care. And you can see that in much of the developing world, in Africa, Asia, and particularly in sub-Saharan Africa, we have a very severe shortage of human resources for health. So you can create all the new information and drugs and scientific discoveries, but if there's no one on the ground to deliver these therapies, if you don't have human resources, you don't have a healthcare system. And this has been the bottleneck in terms of moving forward in terms of human resources for health. And because of this recognition now, the PEPFAR program, which was initially focused on HIV/AIDS almost exclusively, has now moved into a new era called PEPFAR 2, which is basically scaling up human resources for health to strengthen health systems and the capacity for health care delivery, particularly in low resource, low HRH, low human resources for health settings. And again, the U.S. government has made a pledge of $120 million over the next 5 years for the MEPI, the Medical Education Partnership Initiative, to try to scale up and strengthen human resources for health in sub-Saharan Africa. So this is, again, one of the largest investments that our government has made, particularly in health system strengthening in the developing world. And I'm really proud that the University of Wisconsin-Madison is part of the MEPI initiative in Ethiopia. And I'm going to tell you a little bit more about that. But let me also point out that our partnership in Ethiopia really evolved from a very strong relationship. And Dr. Girma Tefera is not here, but Girma is one of our faculty in the UW School of Medicine and Public Health. He's a vascular surgeon. He comes from Ethiopia. And about 10 years ago, Dr. Tefera came to me and Linda Bauman, who's here, saying, you've got to go to Ethiopia, see what you can do to help my country, because there are so many problems. We went, we saw the problems, and we said, we'd love to help, but we've got to have resources to bring to bear on some of these issues. So at any rate, the program is working with 4 Ethiopian schools, 4 schools in the United States, to try to address the issue of severe shortages of human resources for health in Ethiopia. Ethiopia has 80 million people and approximately 2,000 doctors. We have more doctors than the whole country of Ethiopia here in Madison, Wisconsin. There's also a severe shortage of workers. And you can see here the trend of doctors in the public sector in Ethiopia, and the number of doctors has actually gone down in recent years, and gone down partly because of some of the both micro and macroeconomic factors that you heard about from Dr. Coxhead. You can see here the projections. The hope is that right now, Ethiopia has roughly 2,000 doctors, about 1,000 are general practitioners. The hope is that by 2020, they'll have 14,000 doctors. That's a great goal, and you can see also here the scale up for nurses, for pharmacy professionals, for laboratory professionals. There's a tremendous need for, across the board, scaling up training. The MEPI program is aiming to increase the number of physicians, knowing that this is a severe bottleneck currently. The hope is to improve medical education through community-based education, through promotion of multidisciplinary teams, and through human capacity building, that is faculty development, curriculum development, and creating incentives for faculty and physicians to stay and work in Ethiopia. There's a scale up of research and ethics training for the faculty, because we know if faculty are engaged in research, they're more likely to remain interested in being faculty. It makes their job more rewarding. And also, we hope that in 5 years, we're just in the first year of this grant, that we're going to increase the number of medical graduates in Ethiopia by at least 50%. Field training sites will be expanded, and ultimately we hope that this is going to increase access to health care. Now, I've gone pretty quickly through this partnership, but I want to emphasize that the partnership was really built on a relationship. It was built on the values and the principles that we've outlined, and we were able to finally get a match in terms of resource support for the partnership. I think in terms of the global health enterprise moving forward here at UW-Madison, we see some wonderful challenges and opportunities. The interest among students is high, but the number of faculty who actually have in-depth training and experience in global health is relatively low for an institution our size. That's why the incubator and this call for proposals is so exciting. We are seeing a rapid growth and expansion of UW faculty and students who have skills in global health. We understand the tremendous complexity of global health problems. They're intertwined with issues of policy, governance, economics, micro and macroeconomic factors. We also have the challenge of oftentimes the grants do not necessarily match up with the local needs, and often are driven, the grant funding is driven by donors who may not yet be aligned with the particular country or regional interest. And so we're seeing efforts to better align grant funding with local leadership and local priority setting. The opportunities we have are enormous to promote equity in health outcomes, both in Wisconsin and the world. We're expanding rapidly, and we're building capacity here, and you are part of that building capacity. I wanted to go back to the importance of relationships. It always starts with and is based on a relationship to have a strong partnership. The history of a place, a region, the context of its development is extremely important, and paying attention to that history will ensure stronger and more successful partnerships. I also would caution us, I was once told by a village chief in Uganda that I was the most educated person in the world that he'd ever met. But I was really humble in the face of the daunting challenges that I was seeing, and also his local knowledge of his own village and his own region and the things that were likely to work and not to work. So I would strongly encourage humility in partnerships, because in general I feel we have more to learn usually than to give, but these partnerships enhance all of us. And again, persistence in the face of daunting challenges. The Ethiopia case in point, we saw the challenges, we weren't sure what we could do, but by hanging in, by cultivating relationship, we were able to finally find a good fit where we have a chance to really make an impact on healthcare for a major country. So I'm going to encourage both local and global engagement. We've got projects in Milwaukee and in rural Wisconsin that also are reflecting many of these principles of global health partnerships. I think I'm out of time, so I'm going to stop so that there's time for discussion.